Now we start with the third session for the day on portal hypertension. May I request Dr. Dominic Valla and Dr. Yogesh Chawla, the experts for the session, to please take your seats. I'll also like to invite the panelists, the chairpersons, Dr. Arvind Guppi, Dr. Rahul Jain, Dr. Bhaskar Nandi, Dr. Sanjay Sarunke, and Dr. S. Kumar Uguruban. Please take your seats, sir. There are some interesting sessions going on in Hall B also. Thank you.
Can we now invite Dr. Virginia Hernandez to speak on clinical decision making in preemptive tips, setting the goal, post, and the boundaries.
Hello, everyone. First of all, thanks to the organizing committee and especially Professor Akash Shukla for the invitation. It's an honor to be here and to be part of this meeting. So the topic of my talk is preemptive tips, and before starting it, I want to remember what is preemptive tips, and we are now in the setting of variceal bleeding, patient with variceal bleeding. We control the bleeding, and what we want is to prevent failure and rebleeding. So we know that patients with variceal bleeding are still challenging to manage. Even if we treat them according to the guidelines and with vasoactive drugs, we do endoscopy, band ligation, and we control the bleeding, there is around 20% of our patients that will rebleed again, and this is associated with a high mortality and bad outcome. So what we want with the preemptive tips that was initially called early tips based on the time where it's supposed to be placed, but I honestly prefer preemptive tips because I think that this terminology better reflect the aim of the procedure. So it's tips that we place in a high-risk patient after stabilizing the patient after treatment with hemostatic drugs and vasoactive drugs and EVL, and we want to do that early because we want to do that before the patient rebleeds. TIPS is a fantastic treatment to decrease portal hypertension and control bleeding, but it's not a treatment for every patient because you are all aware of complication after the procedure and contraindications in some of the patients. So if we really want to get the best of the preemptive tips in this scenario, we really need to select the population, to select the indication, and there are like a few considerations that I will try to go over. So selecting patients, the most important thing here is to select the patient at high risk of the bleeding. So initially, it was described this high risk as an hemodynamic criteria, HVPE more than 20. This is something that is not available in every center. And the second paper about preemptive tips used this clinical criteria of child B with active bleeding at initial endoscopy, because we all know that vasoactive drugs are very potent at controlling the bleeding. So if a patient is bleeding despite the use of a vasoactive drug, this is high risk, and child C patients. So what happens if we do preemptive tips in all our patients with variceal bleeding with the aim of preventing bleeding? We can prevent bleeding, but we won't have an effect in survival, because patients who have benefit in survival are not child A patients. Those patients do well with vasoactive drugs and EVL, and same thing for child B without active bleeding. So if we put all the patients together according to a broad definition, TIPS does not increase survival. However, if we do select better the population according to the initial criteria, then we see benefit in survival. So what you can see here is all the population together, child B with active bleeding and child C, and then separated by category. And if you look at the Kaplan-Meier curves, then you will see how the effect is not equally in child C or in child B with active bleeding. And this is because in the child B population, there is a subgroup of patients, the one with a low child PUG score, that do not benefit in terms of survival, and the benefit concentrates in those patients with more than 7 points. And when we did the meta-analysis of individual data of all these trials that we have in the setting of preemptive tips, then we can see a nice benefit in survival. And this is why the last Vaveno conference recommended preemptive tips in this particular situation. Child B, more than 7 points with active bleeding. Child C, minor than 14 points, because this is considered futile in 14 and 15 points, and HBPG more than 20. However, when we look at the patients that were included in all these studies, and those are data from the last meta-analysis, we see that, well, the population here was particular in terms of etiology and not very high male. So there are still many questions regarding other patients that were not included in these trials. Contraindication is very important, and we have a little bit of time to check for a few important things. The most important one is cardiac decompensation. This is the most feared complication in patients undergoing TIPS, and also portopulmonary hypertension. So checking with an echocardiography, checking levels of BNP and pro-BNP, and doing heart rate catheterization just before the procedure can help us really identifying those patients with high risk of cardiac decompensation. Also, it has been recently reported that enhanced echocardiography and blood gas analysis can also help us identifying patients with intrapulmonary vascular dilatation that are at high risk of cardiac decompensation. There are special situations, and those are always the clinical questions. It's like, I have a patient candidate for preemptive tips, but bilirubin is high. So those are data from the meta-analysis, individual patient meta-analysis. Still, we have benefit in patients with high bilirubin levels. We have benefit in patients admitted with hepatic encephalopathy. Hepatic encephalopathy is another fear complication. I'm not talking here about the patient who has been admitted with hepatic encephalopathy a long time before the procedure. Those are patients admitted with variceal bleeding and with encephalopathy at that moment, and still here there is a beneficial effect. Same thing with patients with ACLF. Even in the reports that we have from the European cohort, it was only ACLF grade 1 and 2, so not very advanced, but it still is something that we should not contraindicate and evaluate in a patient-by-patient basis. What about time? If we really want to prevent something, we need to do that early. So if the aim of the treatment is to prevent rebleeding, we should anticipate to the bleeding. Why was the 72 initial window defined? It was based on natural history studies, and this is a natural history study from the 80s reporting or demonstrating how rebleeding happens usually in the first 24 hours, but up to 48, 72 hours. And the same thing has been demonstrated in the most recent trials. Of course, 72 hours also give you the window of the weekend to transfer the patient and to put the tips. And this is the definition that was used in the New England study. This concept was challenged from a paper coming from the UK saying that, well, maybe this is not so important. So we decided to look that in the meta-analysis, taking advantage of the big cohort. And what we saw is that the beneficial effect in terms of survival in patients with child C lasts up to 2 weeks. and up to 1 week in patients with child B, meaning that if we have a patient that is a candidate and cannot be accepted in the referral center, we can still have more time to refer the patient or to decide and plan the procedure, and we still will have a benefit in survival. And I think that we do not have that many treatments able to increase survival in the population with cirrhosis. What are the technical considerations? Just a few things. It's always perfect to have a CT scan. As a person who plays the tips, I can tell you that this really help you organizing the whole thing and guiding the procedure. Ultrasound guided portal vein puncture is also something that helps making the procedure more easily and reducing complications. And then there are now we all use cover stent, and there are a few things to take into consideration, not to go very deep into the confluence, thinking that the patient may be a liver transplant candidate in the future, and covering completely the hepatic vein up to the cava vein, because this is the place where TIPS is gonna be dysfunctioning more often. The TIPS does not end in the IR, and it's very important a close follow-up of our patients. We do control with Doppler ultrasound, and those are the criteria that we use in Barcelona. But I think it's also very, very important the medical care of those patients, explaining the patient and the family that hepatic encephalopathy can happen, because sometimes patients, they undergo TIPS and they never had hepatic encephalopathy before. Take care of the diuretics. Sometimes we discharge the patients with the same dose of diuretics, and they are coming back 1 week after with dehydration and hepatic encephalopathy. So take care about all the concomitant medication, beta blockers, and so on. And doing an early control 15 days after the procedure is something that really, really helps. And then when we see during follow-up US signs of dysfunction or clinical signs of dysfunction, we can catheterize the TIPS and deciding on what is the best strategy to attack this dysfunction. So what are, in my view, the overcoming challenges, the challenges that we still have? And I think the most important one is that we are not using TIPS with this aim in our patient, even if I show you all the data that we have. And this is a French study performed a few years ago that the same data, I think, apply now. And preemptive TIPS was not offered to most of the patients. Only 10% of the patients got actually the treatment, and this was based on local unavailability or the lack of belief. So the lack of the belief is something very painful for me when I hear that, based on all the data that we have from the East and from the West, randomized clinical trial and observational trial. So we should be aware of the data that are out there. And regarding availability, not everyone should be placing TIPS now, but we should really work on referral centers and making our patients really go to the center of expertise where they can have the better care. Still, challenges, but etiologies are changing. Our patients are more and more complicated. There are comorbidities. We hear a lot about alcohol consumption. There is sarcopenia. There is age. There are many things that can challenge the thing. And I think that we should work together and having multidisciplinary teams where we can treat the patient before, during, and after, and of course a closer relationship with the interventional radiologists and telling them how important is the patient and also how different is the goal of the pressure in patients with one or other indication. And thank you very much for your attention.
Yeah, we move on to the next talk, and it's a pleasure to invite Dr. Ashish Goel. The topic will be on chylous ascites in decompensated liver disease.
This is it. You can use clicker.
At the outset, thank you, Dr. Shukla, for the kind invite and a challenging topic, mainly because there is very limited data and all of us have an experience of managing an odd patient here and there with chylous ascites. Let me just start with saying that what is chylous ascites? We all know that it is appearance of a milky triglyceride-rich peritoneal fluid, and to demonstrate a leakage on lymphangiography or presence of chylomicrons in ascitic fluid is the gold standard. The surrogate marker that we use usually in the clinical practice is ascitic fluid triglyceride level of more than 200. Now, in addition to the fluid related complications that it has, there are two other issues. One is we are losing a lot of nutrient rich fluid, so malnutrition is a concern. Secondly, there is lymphopenia and immunosuppression. So both of these have to be tackled when we start having chylous ascites in a long term. What are the causes of chylous ascites? We know some of them are directly, so I'm not talking about the children, which is mostly congenital. In adult, it is either invasion or disruption of the normal lymph flow or increased lymph production. Now, disruption could be traumatic, post-surgical, could be because of the fibroinflammation, and a lot of our patients will be either having TB or filariasis, but a retroperitoneal disease is a consideration, and definitely tumor is one of the common cause of chylous ascites. In a background of cirrhosis and cardiovascular disease, there can be an increased lymph production and a flow-related chylous. So this is one systematic review of 40 adult patients with atraumatic chylous ascites, and you can see the most common cause is malignancy, followed by cirrhosis and TB. As far as the traumatic post-surgical chylous ascites is concerned, it complicates most of the abdominal surgeries, whereas retroperitoneal, esophageal gastric or cytoreductive surgeries higher incidence of chylous ascites. Liver transplant per se, around 5% of these patients can be complicated with transient chylous ascites in the post-op period. As far as mechanism, why does chylous ascites develop in cirrhosis? It's unclear, but if it may be related to increased lymphatic flow, increased hepatic venous pressure gradient, which causes lymph stasis and dilated subserosal lymphatics, which break down into the peritoneum. In addition, there is collagenization of the lymphatics if there is long-standing lymph stasis, which causes malabsorption and protein losing and neuropathy. So there are three questions that I had we sort of encounter in clinical practice. If there is a chylous ascites in the background of cirrhosis, how much do we evaluate this patient to rule out any alternative causes? And how do we manage a patient with chylous ascites, and are there any newer treatment options? So to tackle the first question, lymphatic dysfunction is fairly common and under-recognized in patients with advanced cirrhosis. And this is a recent study, where they had taken 155 consecutive patients with refractory ascites, and they found almost 45% with lymphatic dysfunction. Now this can be peripheral lymphedema, intestinal lymphangiectasia, or chylous ascites. The chylous ascites was defined by this traditional criteria, so it's quite rare, but overall lymphatic dysfunction is underappreciated in our patients. When we look at chylous ascites per se, in this study as well, only 1% of total hypertension cirrhotic patients had chylous ascites, but most of them were flow related after a detailed evaluation. So even if we don't evaluate too much with obvious tests, most of them will be cirrhotic related ascites. Again, what is chylous ascites and are we defining it clearly? This is based on the gold standard lipoprotein electrophoresis and presence of chylomicrons. If we use this test, in patients with cirrhosis and ascites, and we see almost 1/4 of our patients have some amount of chylous ascites. So we using a definition of more than 200, but here a cutoff of more than 81 may be more appropriate defining chylous ascites, and really then more than 25% of our patients will have some form of chylous ascites. So essentially what it means is lymphatic dysfunction is fairly common in patients with cirrhosis. So if there are no obvious signs of any other alternate diagnosis on history, on ascitic fluid evaluation, which could be mixed ascites or exudative ascites, we can maybe rely only on a CT abdomen to rule out any other alternative cause. So I would suggest maybe a history taking, a CT abdomen, and an ascitic fluid analysis in most of the situations with cirrhosis and chylous ascites should be enough to rule out alternative causes. So how do we manage? We have to correct underlying cause, but more than that is nutritional balance, which is very important, and we look for high protein, low fat diet. We try and give MCT supplementation in these patients because these are the triglycerides which are directly absorbed in the portal vein and do not go into the lymph chyle. We have to avoid long chain triglycerides. Orlistat can be used for this matter as well. And a more radical treatment would be total parenteral nutrition, which is sometimes applied for post-op chylous ascites. Now, total parenteral nutrition will reduce the thoracic duct flow from 220 ml per kg per hour to 1 ml per kg per hour, and definitely should be going a long way controlling the flow. As far as the fluid management in these CLD patients, it is drain, diuretics, and we may think about non-selective beta blockers to reduce portal pressure. More aggressive treatment to reduce portal pressure is by the somatostatin or long-acting somatostatin analog like octreotide, and in an occasional patient with TIPS. Now, as far as octreotide, very limited data in patients with cirrhosis. This is a study on 6 patients where they have used 100 mg TID for 6 days with cirrhotic chylous ascites and showed significant improvement within a period of 1 week to 10 days. In addition to definitely diet, diuretics, albumin and drainage. In patients who did not receive octreotide, did not show such improvement. As far as TIPS, again, very limited data, lot of case reports, a small series of 4 patients over a period of 8 years showed response to TIPS, and only 20 patients in my knowledge have been reported till date of TIPS with chylous ascites, but quite a good benefit and makes common sense to reduce the portal pressure here. So the proposed management here would be, in a patient with cirrhosis, would be rule out alternate cause. First line would be diuretics, drain, nutritional support, MCT-rich diet, and maybe non-selective beta blocker. If not controlled, maybe octreotide, and if not controlled for a shorter time period, may consider a longer acting octreotide. And in a rescue setting, it may be a TIPS reducing the portal pressure. So as far as the surgical treatment is concerned, this is one case that I am presenting where we have dealt with 41-year-old female who had a donor nephrectomy somewhere in July, developed chylous ascites immediately post-op, which required prolonging of the drains. This was initially managed with drain, nutrition, octreotide with inadequate response. Now, there is a systematic review to guide us in post-op chylous ascites. These are almost 300 odd patients with chylous ascites that have been studied, and what they have found is almost 75% detection rate on diagnostic lymphangiography. The first line management in their review was conservative treatment, which could be total parenteral nutrition with octreotide, and which respond almost 77 to 100% respond within the 2 to 3 weeks. Addition of octreotide is necessary, and in a low volume output, an MCT diet may be equivalent to total parenteral nutrition. The second line treatment remains bipedal lymphangiography with lipiodol injection, which results again in around 35 to 70% closure rate, and the surgical revision is a rescue treatment which is very rarely required. In this patient that we had with post-nephrectomy chylous ascites, we did an inguinal lymphangiography which showed leakage in the renal fossa, we went ahead with lipidol injection and then for subsequently glue into the inguinal lymph nodes with which the ascites settled. A similar data exists in liver transplant, a large sort of a cohort, 516 patients with liver transplant single center, almost a 5% incidence of chylous ascites within a period of 1 to 2 weeks. And there were risk factors, but they seem to be very differential risk factors various across studies. But the outcome was basically very good. There is no mortality, no obvious mortality increase, no graft rejections, and they are all controlled within few days with conservative management of total parenteral nutrition, drain, and octreotide. Rescue surgery was required in only 2 patients. Now, this is an interesting case that we recently had. We were following up this patient, 66-year male patient, diabetic. He presented to us in 2017 with a previous history of live donor liver transplant in 2017 and then having chronic hepatitis B in 2012. 2016 onwards had chylous ascites. Patient was on entecavir, everolimus, mycophenolate and on insulin for diabetes. The initial history was not suggestive of any secondary cause, and there was no lymph nodes or skin changes to suggest widespread lymphatic dysfunction. Liver function, renal functions were normal. Lipids showed a low triglyceride level. Ascitic fluid analysis also did not show any peritoneal disease here. So we went ahead and did a detailed evaluation in this patient. A CT scan showed a chronic portal vein thrombosis with SMV extension, which we thought may be post-op related, and upper GI was normal. Transjugular liver biopsy showed only dilated sinusoids with low HVPG. Lymphangiography did not show an obvious leak. So looks like a flow related problem to us. So this patient was managed with repeated drains, non-selective beta blockers, diuretics and an MCT diet. The further management was questioned whether should we be giving anticoagulation. We did manage with long-acting octreotide. We couldn't consider TIPS because of portal vein thrombosis, extensive thrombus, and should we be stopping everolimus. This patient responded to long-acting octreotide, but there are more and more reports now of sirolimus and everolimus or mTOR inhibitors, which inhibit migration and proliferation of lymphatic endothelial cells, causing lymphatic drainage interference, and there are more reports of these drugs being associated with lymphedema, and there are now case reports of these drugs associated with chylous ascites, which respond well to stopping these drugs. So we didn't stop in this index patient, but maybe some of these patients we will have to take care. So this is the proposed management strategy post liver transplant. If it is early post liver transplant, it's most likely traumatic. The first line of management, which most patients will respond to, are conservative measures, which are diuretics, drainage, nutrition support, and MCT-rich diet, and TPN if there is a high drain output. The second line of management is lymphangiography with lipidol injection. Most of the people will respond at this point of time, and if they do not, then surgical correction may be required. As far as the late flow related problems are there, then most likely patient may we have to go back carefully into the drug history. We have to rule out portal vein thrombosis, any cardiac cause, and manage the causes. Conservative measures are most likely you're going to respond, and if need be, octreotide can be given. So this is the new thing that has come up recently. This is thoracic duct decompression, and not in chylous ascites menu. It is in refractory ascites. There were only a 9-patient study with refractory ascites, which were patients were contraindicated for TIPS and liver transplant. They have done an endovascular lymphatic decompression via the thoracic duct, reaching via the subclavian vein, and they have put a self-expanding metal stents of 5 to 8 millimeter. Now the pressures of the thoracic duct decreased from 19 to 6 millimeter of mercury. The technical success was 100%. Clinical success, which is reducing the flow rate of the ascites drain, was around 33%, but in this group of patients which have contraindicated TIPS and liver transplant, survival was 7.1 months. So whether I'm just putting it out, whether should we be thinking about such measures if there is a difficult to control chylous ascites and there is contraindication to TIPS in these patients. There are multiple drug targets. None of them have really materialized into clinically relevant outcomes still, but the targets are lymphatic muscle cells, lymphadenopathy cells, or even the lymphocytes itself. And there are multiple targets that are being studied. Currently, they are all either not being used or very, very early phase trials. So let me summarize here. Chylous ascites in post-liver transplant setting is rare. If it is early onset, then most likely it is a post-traumatic or traumatic and most likely will respond to conservative measures, which could be TPN and octreotide. If not, lymphangiography is indicated. Surgical revision, very rare. In late, please keep in mind drug and flow-related problems. In patients with refractory ascites, some amount of chyle is underappreciated, and we should look for nutritional support in these kind of patients. Management is expectant in most scenarios. TIPS and local blocking therapy is rarely required, and whether thoracic duct decompression may be of benefit, only time will tell us. Thank you.
Now I invite Dr. Norifumi Kawada to speak on newer strategies to reverse portal hypertension.
Yeah. Well, can I use also this?
Yes, you can use this.
Okay. So, thank you, Mr. Chairman, colleague. And it is my great pleasure and honor to be invited here. Thank you very much for organizers for invitation. And I am very happy to give a talk at this APASL single topic conference in Mumbai. So today I will give a talk on reversibility of portal hypertension newer strategies, COY. So this is the agenda for my talk today. First, I'd like to talk about the mechanism of liver fibrosis, cirrhosis, portal hypertension. So portal hypertension can result from increasing resistance to portal flow and or increase in portal venous flow. In general, cirrhosis accompanying sinusoidal constriction is the most common cause of portal hypertension. Therefore, I mention about this. So this is the anatomy of the liver. The liver is consisted of hepatocyte, bile duct cells, and sinusoids. Sinusoids are composed of L6, Kupffer cell, pit cell, and hepatic stellate cells. I a little bit mention about the hepatic stellate cells. Professor Kenjiro Waki demonstrated in 1970s by using vitamin A fluorescence and Golgi silver method. The seren described by Professor Karl von Kupffer in 1876, and fat stratum cell identified by Professor Toshio Ito in 1951 are seen. As you see in the right lower panel, stellate cell is a relatively large cell body, and they extend well-developed cytoplasmic processes around the hepatic sinusoids. So you can easily imagine the contraction of hepatic stellate cell narrows and controls the diameter of the sinusoid. So in clinical setting, it is customary to express measurement of portal pressure as the gradient between wedge hepatic venous pressure and free hepatic venous pressure, that is HVPG. In cirrhosis, in case of cirrhosis, intersinusoidal communications are blocked by extracellular matrix deposited and stellate cell activation. So we need to understand the mechanism of liver fibrosis. When liver hepatocyte damage takes place, fibrin deposition and platelet activation induce the release of several mediators. In response to these stimuli, circulating inflammatory cells accumulate at the site of hepatocyte damage. Then stellate cells become activated and produce a basement membrane-like substrata. In case of chronic liver injuries, hepatic stellate cell activation persists and they secrete extracellular matrix, including type 1 collagen, into the space of this cell. And also they are the good source for the inflammatory or site fibrous mediators. So stellate cell activation is initiated by the mediators from the cells around the hepatic stellate cell in chronic liver disease. And furthermore, regarding the L-sex, capillarization and endothelial dysfunction takes place in cirrhosis. So finally, in liver cirrhosis, TGF-beta activated hepatic stellate cell secrete large amount of type 1 collagen in the space of this cell, and they undergo contraction by stimulating increased endothelin-1 and angiotensin-2 and decrease of nitric oxide. On the other hand, L-sex become capillarization by stimulated by the VEGF production under the hypoxic condition. So sinusoidal portal hypertension takes place in cirrhosis. So in portal hypertension, furthermore, a splanchnic systematic vasodilation leads to a decrease in effective arterial blood volume that activates sodium-retaining neurohumoral system that leads to plasma volume expansion and hyperdynamic circulatory state. Furthermore, due to the bacterial overgrowth and translocation and the release of PAMPs, TNF-alpha and IL-1 beta in cirrhosis in mesenteric and peripheral vasculature, vasoconstrictor endothelin-1 and angiotensin-2 decrease. But vasodilatation, the nitric oxide increase, so leading to the vasodilatation and the hyperdynamic circulation. So then, I would like to mention about reduction of portal hypertension. Is it possible? So previously, it was considered cirrhosis is a not progressive chronic process, but an endpoint. However, recent clinical evidence demonstrated withdrawal of the injurious agent can allow remodeling of the fibrillar matrix, leading to altered attenuated cirrhosis. So cure or control of underlying liver disease, for example, like hepatitis virus B is controlled by nucleic acid, and hepatitis virus C is controlled by DA treatment, and alcohol abstinence, so on. Now we know is induce fibrosis regulation and portal hypertension repression. For example, as you can see in the left panel, in patients with cirrhosis due to hepatitis virus B infection, lamivudine monotherapy reduces HBPG, especially when biological suppression is achieved. As you can see in the right panel, this study showed tenofovir is a variable treatment for viral suppression of HBV and is associated with long-term histological improvement, including reversal of cirrhosis. And this is a paper from Taiwan showing the 4-year NWS treatment reduces cirrhotic events in HBV patients. So 4-year NW therapy reduced varicella bleeding, spontaneous bacterial peritonitis, liver-related mortality, and all-cause mortality. Regarding the hepatitis virus C, Already in 2012, the umbrella shows and so on reported after 1 months from SBR, cirrhosis regression was observed in 61% of patients and the creatinine content decreased in 89%. And right panel shows our data after the DAA-induced eradication of the hepatitis virus C. As you see, alpha smooth muscle actin positive, green fluorescent positive stress activated stress cell remarkably reduced in number at SVR24. Furthermore, regarding the HBPG, as you can see in the left panel, in patients with SCB-induced cirrhosis, if hepatic venous pressure gradient is less than 16 mHg before DA treatment, SCB elimination induced the significant decrease of HBPG at SVR. So as you can see in the right panel, our group demonstrated even in decompensated liver cirrhosis, soft bell-induced eradication of hepatitis virus C induced the regression of portal hypertension. So this is the summary. This review article summarized the long-term benefits of DA treatment for SCB cirrhosis. So this shows the portal hypertension decrease, decompensated liver cirrhosis improves, complication of liver cirrhosis reduced, and removal from the liver transplantation wait list is achieved when SVR is achieved. So finally, I would like to mention a little bit about the newer strategies for reversibility of portal hypertension. So as I mentioned, underlying liver disease is cured or controlled, we can observe the portal hypertension regression. So if a similar effect could be achieved through drug therapy, in addition to the removing the cause of the disease, it would be possible to treat portal hypertension. So based on these ideas, targets currently being studied include antioxidants, anticoagulants, and cell activation inhibitors, and so on. So first, I would like to mention about carvedilol. It's a non-selective beta blocker and is commonly used in the management of portal hypertension, particularly in patients with cirrhosis and related complications such as variceal bleeding. Carvedilol effect is caused by a reduction in the portal hypertension, prevention of variceal bleeding, improved hemodynamics, and several studies suggest carvedilol may be superior to traditional beta blocker like propranolol in controlling portal hypertension, likely due to its additional alpha-1 blocking effect. As you can see in the left panel, a randomized multicenter open-label study evaluated efficacy of carvedilol versus propranolol to reduce portal pressure in patients with liver cirrhosis. So carvedilol achieved significantly higher target reduction rate of HBPG among more advanced cirrhotic patients. And as you can see in the right panel, carvedilol achieves a higher hemodynamic response and lower rebleeding rates than propranolol in secondary prophylaxis. So next, I'd like to mention about statin. Statin is used to manage hyperlipidemia by inhibiting HMG-CoA reductase and also show potential benefits in conditions like portal hypertension. Their effects can be caused by the reduction in intrahepatic vascular resistance, antifibrotic effects, systemic and splanchnic effects, the anti-inflammatory effects and improvement in outcome on complications. Already several clinical studies demonstrated the effect of statins on the portal hypertension. For example, as you can see in the left panel, proof of concept study demonstrated effects of atorvastatin on portal hemodynamics and clinical outcome in patients with cirrhosis with portal hypertension. As you can see, the statin reduces HBPG in cirrhotic patients. And as you see in the right panel, this double-blind placebo-controlled randomized trial shows hemodynamic effects of carvedilol plus simvastatin in cirrhosis with severe portal hypertension. And the carvedilol and simvastatin combination therapy significantly enhanced the HBPG lowering effects achieved than carvedilol alone. So finally, I would like to mention a little bit about FGF21 agonists. Eflexfermin is an engineered FGF21 fusion protein being developed as a potential treatment for MASH. And effect of this compound is derived from reduction of liver fat content, decrease in liver fiber inflammation, improves fibrosis, and metabolic benefits. Now this compound is in clinical phase 3 studies, and enrollment has been finished. So we are waiting for coming the result of this clinical studies result. However, already the phase 2 trials demonstrated in patients with compensated cirrhosis due to MASH, eflexfermin showed significant rate of MASH resolution, reduction in mark of liver injury and fibrosis, and improvement in markers of glucose and lipid metabolism. So we are waiting for coming these drugs for MASH liver cirrhosis patients. So this is a summary of my talk. Thank you very much for your attention. Thank you very much.
Okay, Dr. Akash for the case presentations.
Good afternoon, everybody. So far, everybody has been either thanking me here for the invitation or have been blaming me for the difficult topics that I have given to them. When I had made this program, I had only one session that was on Sunday morning, which was a panel discussion. And then as people started dropping out, Dr. Amit Gupte, who was helping me with drawing the program, kept on putting me. So thank you, Amit, for giving me these topics. So this is not working. So this is a 43-year-old gentleman, alcohol-related liver cirrhosis with portal hypertension, who presented in 2023 with variceal bleed with a hemorrhagic shock. The MELD score was 16, CTP 8B. Endoscopy showed large junctional and fundal varices. Glue injection was done. Patient improved and was discharged, was subsequently lost to follow-up. and came in, a CT scan at that time showed cirrhosis with a span of 17 centimeters, dilated portal vein, a left gastric vein which was dilated, and small linear shunt draining into the left renal vein, and moderate ascites. Came in December 2024 with a GI bleed. Endoscopy done showed 2 columns of grade 2 varices without any red cherry signs. On endoscopy of the stomach, there were fundic varices which were partly solidified, and there was an area of 1.5 centimeter by 1 centimeter which was still soft. There was no active bleeding on endoscopy. So we had these options in front of us. Should we repeat a glue? Should we do a TIPS? Or should we do a TIPS plus BRTO? We went ahead with a HEPG measurement. The HEPG was 26. We did a TIPS. After TIPS, the pressure came down to 14. But what we saw was there was persistent flow through the varices, and therefore we decided to go ahead with embolization as well after the TIPS. This was another patient, 49-year-old gentleman, alcohol-related cirrhosis of liver. He had recurrent GI bleeds with multiple sessions of band ligation and glue for both esophageal and gastric varices. He had presented to us in May 2023 with a large fundic varix, and the esophageal varices had been eradicated at that time. The MELD was 14, and a CT scan showed large fundic varix with large gastrorenal shunt. So the linear renal shunt was cannulated and occluded with a balloon. Subsequently, the coil and glue injection was done with a histocril, and a complete obliteration was achieved in this patient. Within 48 hours, the patient started with a variceal bleed. And what we did, when we did an endoscopy in this patient, in 48 hours, after we have obliterated the gastric varices, we saw 3 columns of grade 2 varices with active esophageal variceal bleeding. A band ligation was done. The fundic varix was already solidified completely, and therefore we decided to go ahead and do a TIPS for this patient. The opening pressure was 24, the gradient was 18, and post TIPS, patient had a gradient of 8 millimeters of mercury, and patient has done well since then. We are all familiar with the Sarin's classification of gastric varices. If you look at the anatomy of the flow for the gastric varices, the afferents could be from the short gastric vessels or the posterior gastric vein, or if you go distal, that is closer to the liver, then it could be from the left gastric vein, which can also supply the blood. It usually supplies the blood to the esophageal varices as well. The efferent would usually be through a gastrorenal shunt, or to the hemiazygous system, or from the splenic vein to the renal vein through a splenorenal shunt. The interventions that we can do radiologically are only TIPS, only BRTO, TIPS plus BRTO either concomitantly, or TIPS before BRTO or BRTO before TIPS. We can do TIPS plus bland embolization either concomitantly, or delayed embolization for rebleeding, or we can do a TIPS plus BATO either concomitantly or delayed embolization for rebleed. When we do TIPS, what are we doing? We are creating a low pressure system, and therefore you expect the flow in the left gastric vein, which is the closest amongst all these collaterals, to actually reverse and become what it should normally be, and therefore decompress the varices, both esophageal more effectively, gastric varices a little less effectively. When we look at the hemodynamics of BRTO, when you occlude the GRS and the fundic varices, you do not, you still occlude the afferent pathways to the gastric varices, and you expect the blood to preferentially flow through the portal vein into the liver. But if the left gastric vein is still patent and it is supplying the blood to the esophageal varices, then that can actually have a paradoxical increase in the flow, which can cause appearance of the esophageal varices or worsening of the pressures in the esophageal varices. And this can cause worsening of the portal pressure in general and precipitate esophageal variceal bleed and other complications of portal hypertension. When you do BRTO, theoretically we can offset the problems with each of these two procedures because you are creating a more controlled shunt. And that was the preliminary data. The ascites and hydrothorax rates reduce, the rebleed rates are lower with the combination as compared to each of these three alone. So it looks like a win-win situation because you are replacing a natural portosystemic uncontrolled shunt with a controlled portosystemic shunt. The portal pressure which has increased after the BRTO is expected to be controlled because now you have placed a TIPS. The lesser risk of encephalopathy than TIPS alone because you are closing another portosystemic shunt which is the gastric varices. And because you are doing both of these, there is at least in short term a decreased overall rebleed rate. So this was the data, initial data by Saad and Sabri, which led to this combination being increasingly used. But then came a dampener. This was actually an abstract by Saad, which is a retrospective analysis of multicenter US database, which looked at the combination of BRTO only versus BRTO and TIPS for management of gastric variceal bleeding. And if you look at, as expected, the rebleed rates are better with the combination. The significance, ascites recurrence is much better with BRTO and TIPS. The survival in patients with BRTO plus TIPS is better than BRTO only. But when you look at the last part, BRTO plus concomitant TIPS actually had lower survival as compared to BRTO plus prior TIPS. And therefore, it actually got me confused. But when we look at the details in the methods which were given, it was a retrospective audit of the patients. And the definition of the concomitant was TIPS created within 2 weeks from the BRTO. So it was not done on the same day. So probably these were the patients where BRTO was done and then there were some indications to do TIPS as well, which probably was because these patients were more severe liver diseases, probably more severe portal hypertension, and that is why the TIPS may have been done. Purely my hypothesis, but that is the most likely explanation, and that is why we can explain the higher mortality in this group. This was a meta-analysis published in 2021. As you can see, very limited randomized control trials, only one in fact, all other are retrospective studies or just prospective observational cohorts. When we look at the rebleeding rates, as expected, it's much better and after in gastric varices, as you can see, it's much better with BRTO. Rebleeding rate from esophageal varices are better with TIPS. When we look at the complications, liver failure is much more common with TIPS as compared to BRTO. Encephalopathy, much more common with TIPS than BRTO. Ascites, much more common with BRTO than TIPS. And worsening of esophageal varices, as expected, much worse with BRTO than TIPS. And then this systematic review and meta-analysis published in 2023, which looked at the risk of rebleed rates from all the trials, which looked at TIPS with or without embolization, and TIPS plus embolization was better than TIPS alone. But there was no difference in shunt dysfunction, encephalopathy, or mortality. What is the problem when you interpret this sort of a data? Portal hypertension and cirrhosis is a very heterogeneous population. And if you look at the inclusion criteria in these studies, it has been really diverse. The confounders are several. Some of them are impossible to objectively measure with the currently available tools, like the thickness of the varices, the intravaricial pressure in gastric varices or the esophageal varices, the direction and the volume of the flow, of the inflow or the outflow of these varices. So these are some of the things which can be very difficult to gauge and which might impact the way we treat these varices. And thereby it becomes very difficult to really match the groups, and therefore we hardly have any randomized control trials in this field. Most of them are single arm or retrospective studies. So what are the factors which we take into account when we decide what we are going to do with our patients? We look at the liver function, which is Professor Patrick Kamath taught us almost 3 decades ago that for doing TIPS, you have to look at the MELD score. We look at the severity of portal hypertension because we know that the higher the HEPG, more is the risk of bleeding, and therefore lowering it with TIPS is going to help. We look at the anatomy of the collaterals, the afferents, the efferents. You have to start thinking like interventional radiologist, which procedure is technically feasible and which one is not. And then you have to look at the anatomy of the varix itself, how much of it is projecting really into the lumen and how much of it is intramural or extramural. And then you assess the risk of bleeding from these varices, if they've already bled, risk of rebleeding, etc. And then you take a final call. So, like I said, there is no robust data to support one particular way of management. So what is our algorithm? Our institutional algorithm for rebleeds, if we find a GOV1, we look at whether the person is TIPS eligible or not. If the patient is TIPS eligible, we go ahead with TIPS. After TIPS, on table, if we find that there's persistent significant flow in the gastric varices, we do a BATO in the same setting. The patient is TIPS ineligible, we do go for obliterative therapies in these patients. In presence of IGV1 and GOV2, we see whether BRTO is feasible or not. If the BRTO is feasible, we do a HEPG immediately after doing a BRTO. And if we find that the HEPG is more than 20, then we do the TIPS in the same sitting. If the BRTO is not feasible and patient is TIPS eligible, then we offer TIPS to these patients. Thank you very much, and I'll be happy to answer any questions.
A big thank you to all 4 speakers for these beautifully concept-loaded talks. Now I'd like to request our experts to take forward this session. To wrap up the session with your ideas, might as well take questions as they come along. Thank you.
Yeah, very briefly, all these talks were excellent. I would just summarize and review whatever has been said. The first talk on preemptive TIPS told us that patients with Child's Puke score B or those with C with a total of less than 14 would be good candidates for preemptive TIPS, but one has to look at the contraindications, especially the cardiac dysfunction and portopulmonary hypertension, to be aware of this before you take up this. Unfortunately, preemptive TIPS is not very widely practiced, but whatever literature is available, Dr. Virginia said that it improves the survival if it is done within 72 hours. What has not been mentioned is the patients with HCC who have portal vein thrombosis and have presented with a variceal bleed possibly may be good candidates for preemptive TIPS, and so also patients who are put on A plus B therapy in HCC, immunotherapy. These patients are more prone to have a bleed. They also could be possible candidates for preemptive TIPS. I would request your opinion on that.
Thank you very much for the question. Those are like very important and timely questions. I think that we still have no data in HCC to really support the concept, but we are all aware that this is changing, that patients, they live longer, and they were traditionally excluded from all the studies, especially in the preemptive TIPS setting, and this is why we have no data, but it's something to rethink based on the new survival that these patients have. So I guess that we will have like data in the future regarding this topic, because the whole scenario is changing and maybe excluding not all, but a subgroup of patients probably would really make the difference. Yeah.
Right. Thank you. Ajay, we'll just come to your question after a while. Then the second talk by Dr. Ashish on chylous ascites and cirrhosis, something which is very rare in this group of patients. But what I really liked was that looking up for chylomicrons and looking for triglyceride levels more than 81, possibly may be able to pick up more cases of chylous ascites, and especially so in those who have refractory ascites. And I also liked the treatment of thoracic duct shunting, and doing TIPS in these patients could be a possibility. So something, and after you have ruled out tuberculosis and malignancy as a cause of chylous ascites. I don't have much to say on this for a rare condition. Then Professor Kawada's talk on reversibility of portal hypertension. We have enough literature now on recompensation of the liver, and recompensation after treating hepatitis B, hepatitis C, which happens in about 25% of cases, and alcohol withdrawal. These are good examples where portal hypertension decreases after you have treated the etiology. Apart from the drugs like carvedilol, which has been shown to decrease portal hypertension, but unfortunately, statins and FGF21 agonists, although experimentally they have shown a decrease in portal hypertension, but the chances of variceal bleed, specifically with statins, have not been proved from the few studies that are available, especially simvastatin that has been tried. And the last talk by Dr. Akash, where he has highlighted that whenever these patients of bleed come, you should assess the anatomy of left gastric vein and the gastric varices, including splenorenal shunt. If splenorenal shunt is predominant with gastric varices, BRTO should be the ideal answer. And if you have refractory variceal bleeding from esophageal varices, then possibly TIPS is the answer for such patients. And occasionally you may require both BRTO as well as TIPS, because BRTO doesn't decrease the portal pressure and it might aggravate the HVPG and predisposing these patients to recurrent variceal bleed. Ajay, you were responding, and may I request the audience to come up with some questions so that the speakers would be able to answer.
No, I have a question for Linia. I think very nice talk, and maybe Akash, you can also take this up. Whatever you mentioned about the preemptive tips, this applies, and we have more guidance or guidelines for those who are bleeding from esophageal varices, right? But then what is your thought on preemptive tips for gastric varices? And why I'm asking this is that in the recent ASLD meeting, there was a multi-center European study. What they had done was that after the initial obliteration of the gastric varices by glue, they randomized these patients into two groups. One, they did the preemptive tips, and other, they continued with the glue. And they showed that the 1 year survival and the rebleeding was lesser where they did the preemptive tips in gastric varices. So my question to you is about the gastric varices preemptive tips. Maybe Akash, you can also.
Thank you for the question. So we have two trials performed in this setting. The first one was an Spanish trial that was not completely, we couldn't achieve the sample size due to COVID and so on. But the preliminary data show a beneficial effect in preemptive tips in gastric varices, and this was published in GF reports. The second one, as you said, was discussed last ASLD. We are still waiting for the full publication, but the data are very nice in terms of efficacy of the tips, but also I was shocked when I learned about all the complications of cyanoacrylate in their population. They have like severe complications in the control arm. So I think that yes, gastric varices may be also good candidate, these patients, for preemptive tips. However, as Akash said before, it's very important to look at the anatomy, because not all gastric varices are a good candidate for tips. And then in the preemptive tips scenario, I think that you have time to really think what is the best strategy if you really want to go for tips, or combining the two treatments. Now that I'm having the microphone, I would like also to have Akash opinion on the time of doing BRTO and tips in these cases of gastric varices, because from a technical point of view, makes a little bit more sense, like doing the tips first, and then you have the access. So going directly to embolize the splenorenal shunt may be a better approach than the other way around and doing BRTO first and then the preemptive tips. Thank you.
Yeah, completely agree with you, Virginia. That's much easier if you do a tips, and then you can go through the tips into the portal vein, and from there you can go and embolize the varices. The challenge happens is if somebody has a borderline reserve, liver reserve and borderline liver function, then, and if they have a suitable anatomy to go through the gastrorenal shunt, if it is good enough or big enough, then usually if it is isolated gastric varix, we would go through that shunt and do the embolization first, and then we measure the HVPG after we have embolized this. And if you find our threshold, arbitrarily we have kept at 20, because that's the rebleed level. It's completely arbitrary, but that's what we do. And then if we find it's more than 20, then we go ahead and do the tips.
Yeah. Hey. I'm Raj Reddy from Philadelphia. I had a question for Dr. Goyal, and actually a couple of comments. Is he around? Yes. So it was a great talk. So I'm wondering whether what you describe as chylous ascites is truly chylous in all cases, because mechanistically they might be different. Transection of lymphatics post-surgical chylous ascites might be different than the ones you see in cirrhotics. You know, you used to use the term pseudochylous ascites. There's a little bit of chylomicrons, a little bit of triglycerides. To that end, have you looked at etiology of cirrhosis and this phenomenon? My hypothesis would be that most often it is seen in alcoholic cirrhosis. I'll tell you why, from my end, because in alcoholic cirrhosis, the pathophysiologic mechanism is around the central vein, and they have periveneal sclerosis, and lymphatics traverse the perisinusoidal space, and they're very pressure sensitive. So a little bit of block there, just like post-sinusoidal block, you see chyle come out into the abdomen. So to me, the chylous, quote-unquote, ascites that you see in cirrhotics is nothing different than the garden variety refractory ascites. So I don't want to make it a separate, unique entity is what I'm trying to get at.
I would agree with that, sir. Though there are very little studies, the recent data, what has been shown is there is more the chylous ascites if we define it at a lesser level in patients with refractory ascites. So looks like if we keep on giving the definition as lower and lower, we are going to get more and more of chylous ascites in refractory ascites. As far as the etiology is concerned, I think most of the studies have looked at refractory ascites. Most of them are alcohol, but there is not enough data to say alcohol is most often the cause.
One point is regarding portal vein thrombosis and advanced HCC. There are good studies which have already proved advanced HCC with portal vein thrombosis, if we do TIPS followed by sequential therapy, then median survival is 9 to 12 months as compared to 4.8 to 6 months in patients who are given symptomatic or supportive therapy only. And second question to Dr. Akash, he totally skipped US guided gastric varices management. Only tips and BRTO is discussed. In between, if endoscopic therapy fails, the first step is to do US guided management of gastric varices rather than going for tips and BRTO. And third problem is doing concomitant BRTO and tips. Practically, you do BRTO and wait, or you do tips first and then wait. Doing concomitant in one sitting, I think literature does not support this.
Thank you, sir, for those comments. Unfortunately, again, like I said, there are only case series which are available for even for US guided coiling. There is no good randomized control trial showing the superiority of US guided coiling over TIPS or over BRTO. The other problem is when you just do a coiling, it's very similar to doing a BRTO, and it can aggravate the portal hypertension. Unfortunately, nobody has even studied. At least here with BRTO, we have that data, how much is the portal hypertension worsening. So I think US coiling is right now a tool which we have still not learned where to use it in the right way. So I think I'm not eligible to answer the first question about HCC. That was beyond the purview of my topic. Thank you.
If I can comment a little bit of the PVT and HCC, I think that the most important for me in this case is to evaluate the portal vein thrombosis to really make sure that it's not a tumoral portal vein thrombosis. Because if it's a tumoral portal vein thrombosis, then I will I will manage the patient without a TIPS. This is palliative care. Then if it's not, well, there are like many other things that take into consideration for the decision, how severe was the bleeding, the age, liver function, many other things. We have like no solid data to recommend tips in this scenario, but there are definitely some patients that may benefit.
Okay, thank you. Thank you very much to all. Pat, the question, very short.
If you can just follow up on Raj. Raj, our experience is absolutely like yours. It is alcohol-related cirrhosis. They get the typical histological feature. And retroperitoneal lymphangiogram is, bipedal doesn't help because it picks up retroperitoneal lymphatics. For hepatic lymphatics, that's the MR lymphangiogram, which is a newer technique, and that can be used to actually embolize lymphatics.
Okay, thank you very much. Thank you to the speakers. The program was wonderful. And so I think it's now time to close the session.
Thank you, dear experts, for all your comments. Thank you, chairpersons. So now we'll be parting for lunch. Lunch is in the theatre hall, and we'll reconvene exactly at 2:30 p.m. Also, there are interesting e-posters of selected abstracts being displayed in the pre-function area. Do kindly pay a visit. Thank you. See you all at 2:30 p.m. Thank you.